Onc Live Insights is a video editorial program produced by Onc Live.
The COUGAR-302 study was a very large phase 3 study that occurred in 12 countries. And it initiated enrollment in 2009, and we had initial outcomes data on the progression-free survival endpoint in 2012. However, it took until mid-2015 until we had mature survival data. Now that was, of course, very good news because the overall survival is quite long. It's the longest we've ever seen in a study of men with castration-resistant prostate cancer. The median survival for men who were treated with the Abiraterone arm, on the Abiraterone arm, was a little bit more than 35 months. And that compared favorably to the median survival of 30 months of the patients who received prednisone and placebo initially. Now, in order to really understand these data, you need to understand what happened in those 4 to 5 years of the study conduct. Number one is Abiraterone itself became approved and available in most countries. And as a result, 44% of the patients who were initially enrolled in the placebo arm went on to receive Abiraterone at some point in their life. And so there was a tremendous Abiraterone crossover effect. There was also a significant amount of subsequent therapy with docetaxel, cabazitaxel, and even enzalutamide in both arms of the study. And so this resulted in the survival curves requiring a relatively long period of time to become fully mature. The final point about the survival analysis is that when we first presented it and published it in 2012, it was not a statistically significant difference in overall survival. But when one sees the evolution of the curves, one sees that when we did that initial presentation and publication, the curves were really just beginning to separate. And by the time we get to the median follow-up that we have now, we see a very, significant and persistent separation of the survival curves. One of the key landmarks in the life of a man with metastatic castration-resistant prostate cancer, especially one who doesn't have pain, is the development of pain. As clinicians, it's an event that we seek to delay and avoid altogether. And with that in mind, the time to first opiate use was a critical secondary endpoint in the COUGAR-302 study. And in fact, this study enrolled patients who had very little to no pain that was associated with their disease. And in fact, patients were required to not be taking opiates at the time of enrollment. So when compared to prednisone and placebo, the Abiraterone plus placebo patients went about a year longer before they required opiate analgesics. That's the median time to opiates. That's quite a significant time when you think about it, 1 year less of opiate requirement. And so that's a very critical, I think, clinically useful and very meaningful endpoint that clinicians and patients can relate to. Interestingly, it took a long time for the majority of patients on the study to require opiates, and so this was one of the later endpoints that matured. With regards to the safety of Abiraterone with long-term use, it's important to say that there were no new safety signals that emerged in the second or third year of therapy that we were unaware of. I think it's also useful to point out, and there's data presented today at the AUA meeting here that show that corticosteroid type toxicities are really not that significantly they don't increase over time. There are corticosteroid toxicities that do occur initially at the outset of Abiraterone therapy, but the cumulative toxicities from corticosteroids was, I think, less than we expected, and is in Abiraterone plus prednisone treated patients not quite different from patients who simply are receiving 10 milligrams of prednisone on a daily basis. Stopping Abiraterone is one of the more common questions that I get. When should I stop? When do we declare that the therapy has stopped working, and those types of things? There's a couple of answers to the question on when is the ideal time to stop Abiraterone. First of all, we can look at the clinical trial that we've been talking about, 302, in which patients did not discontinue the Abiraterone because of a rising PSA. In fact, there was a fairly lengthy time interval between when PSAs began to rise and when radiographic progression occurred. In many cases, it's 6 or 7 months. And in some cases, I've had patients who continue to take abiraterone for well over a year or even longer without requiring discontinuation. So I think that, that early discontinuation because of a simple rise in the PSA may actually be doing patients a disservice. I do believe that continuing the therapy may continue to slow down the progression of the disease, and some of the data we have from the 302 study bears that out. Of course, if a patient is developing progressive disease with progressive symptoms and objective progression, new lesions on bone scan or new visceral metastases, then that is a situation where, in general, it's clinically prudent to discontinue the abiraterone. I will make a final comment, which is that we are doing a lot of work now to look at the various different ways biologically that the disease can progress. And one thing that's important to know is that there are patients out there who will develop progression of disease and maybe even symptomatic progression in an isolated or one or two metastatic sites, and sometimes those can be treated with radiation therapy, for example, and the systemic benefits of abiraterone or another systemic therapy can be continued. And so I would urge clinicians to really evaluate progression as its own event and look at it and ask the question, is it global progression, multiple sites and general decline, or is it an isolated progression? And if it's an isolated progression, considering doing something like either a focal radiation therapy or something along those lines.